Let's have a case discussion now, and we can have the questions at the end of this case discussion if there are any regarding enhancing sperm quality. So Dr. Raghavender Kosgi is going to moderate this session, and we have Dr. Parshuram, Dr. Vineet Malhotra and Dr. Mohammed as a panelist for this session. It's about enhancing sperm quality.
So, good morning to everyone. At the outset, I would like to thank ISAR organizing team and Dr. Ranjit Ramaswamy for giving me this opportunity. And it's an honor to me to moderate this session in front of my gurus Dr. Rupin Shah and Ranjit Ramaswamy and my practical guru Dr. Vineet Malhotra. So you have wonderful session now, theoretical background with all the topics. Probably this theoretical knowledge, how we are going to translate into our clinical practice. Let's see with the case discussion. So here is a case scenario 1, a 33-year-old male with unremarkable medical history, married to a 31-year-old female for 5 years. He had 4 miscarriages from natural conception in the first trimester and 2 IUIs failed in the last 3 years. Female workup for recurrent pregnancy loss is unremarkable, and physical examination was also unremarkable in the male, and hormone profiles are also normal, and he has already used antioxidants because IUI failed, other things are there. So what is the next step in this scenario, Dr. Vineet?
No, have you mentioned a semen report here?
Yes, that is what the next labs, that is the semen analysis. How will you interpret this?
Yeah, so this seems to be a normal semen report, and you've mentioned it as progressive, which I assume is, we'll split it up and say 20 rapid and 20% slowly progressive. And so I would then order a DFI in this patient.
So exactly what is the case scenario we are dealing with here, where female is absolutely
normal? This is
normal.
Unexplained infertility, which means that you have normal parameters, and we still have infertility. We have a physical examination which is also normal. The semen, a semen report without the advanced semen examination, which is also normal, and I'd want to have this would be an indication to do a DFI in this patient.
Yeah, it's a true case scenario where it is an unexplained infertility in both in male and female. Just can you differentiate what is the idiopathic male infertility versus unexplained, just for the audience sake? Idiopathic versus unexplained.
Yeah, so if you have normal semen parameters and unexplained and infertility, then this is unexplained infertility. And if you have abnormal semen parameters but no identifiable cause for the infertility, that's idiopathic male infertility.
So this is an unexplained infertility. So what additional? Already you have mentioned. What are the additional tests you require, Dr. Parshuram, in this case? Yeah, Dr. Parshuram.
Actually, in this case, when we have like these 2-3 miscarriages, also I recommend to do the genetic testing, PGTA, for on the embryos, to check if they are euploid or unemployed embryos.
So before going to that, probably now you have to evaluate further. Dr. Parshuram, anything else you do as a clinician in this case scenario?
Basically, I think one of the reasons we don't do a DNA fragmentation earlier is we have something to do now. Most of the time we don't do a DNA fragmentation, so now we will do it and say that, yeah, now we have found a reason. But otherwise, technically speaking, now you have also said that you've given 6 months of antioxidant therapy and things like that. So technically, even if you end up doing your DNA fragmentation and if it is high, you are still going to give your oligo now. So it is not really going to make it.
So I agree with Mohammed there that this would be a patient where karyotyping would be something that I would consider, because rarely you could have certain of the rarer karyotyping anomalies that could lead to recurrent pregnancy loss. And though you would still possibly hope for abnormal semen parameters also, you may not see that there.
Anything else you want to do? Because this is an unexplained infertility is a dilemma in our clinical practice, how to go about these case scenarios. One thing you said karyotyping, PGT, and another thing you said DFI. Anything else we can do here? That is a genetic evaluation for thing. Because in Indian scenario, anyone can do this asymptomatic infections contributing to this and nobody who is testing, and another advanced genetic testing just only for the discussion sake, even though.
One thing I want to add as a continuation of what was said before, because I think this needs some clarity in the sense of PGT testing. Please correct me if I'm wrong, sir. See, I think the whole idea that we are talking about PGTA is screening. Basically you are only screening. All right. So you have 5 embryos, you are screening. Second and fifth embryo are normal. So you are able to transfer that second embryo first time and you are going to get a pregnancy. If you don't do PGTA, first embryo transfer might not give you a result or probably end up having an abortion, but you still end up transferring the second embryo which would have got you pregnancy. So by doing a PGTA, you are only shortening your time to pregnancy and not your overall cumulative pregnancy rate. So that has to be very clear. So a PGTA is very different from when you actually see a chromosomal abnormality and we end up testing the embryos. That time we are talking about either PGT-SR or PGT-M, where you are actually, that is a very relevant situation where we end up doing a PGT-SR or M and selecting the embryo without having the deformity and then doing a transfer. So I think that clarity has to be clear. So PGTA never improves your pregnancy rate, only decreases your time to pregnancy.
Yeah. Before going to the embryology lab, can we do anything as a clinician? So this is the area where another lab test is done, DNA fragmentation testing was done.
Can just add one thing here?
Yes.
That's true, that like if you look into the cumulative pregnancy rate, that's true. At the end it will be the same.
Mike.
I have one. I think regarding this situation and the miscarriages and no pregnancies with these cases, I think nowadays there's a lot of talk about like functional medicine, and they look into the toxins, look into toxins in the female or even in the male, and when they found like high levels of these such toxins, and when they treat the patients and lower the toxins in their body, they got pregnant on their own and get a healthy pregnancy. So probably it's not like it's a good idea to look into these toxins if they are in the female or male.
Yeah. So this patient has gone ahead with the sperm chromatin structure assay. His DNA fragmentation is 45. Dr. Vinith.
No, let person.
Yep. Is DF as a clinician, what will you do? Patient is with DFI report now. What exactly will you do?
So,
Already on
Aligo
taken
4
my
is used
answer.
already.
So we are assuming that they've been told all the factors that would modify the DFI, which means they've been attempting. So, sorry, those pregnancy losses were ART attempts or were they
2
natural?
IUIs and 3 natural attempts.
So, I'm assuming that all lifestyle factors, if any risk factors existed, shorter abstinence times, and oligocare fort has also been taken, and then we have it. So, if we still have a DFI which is high despite the measures, I'm going to look at using testicular sperm then for ART.
So, Dr. Parashuram, will you also do the same SESA or anything else? You do any other test?
No, I think obviously your tunnel assays and all are probably more specific and more sensitive, but I think what is available here is mostly SCD and SESA. No?
So I have a point to make there. My point is, when you compare assays, if you are doing one at baseline and when you're doing one, say 3 months later, and you want to check if you're looking at something like SCD, make sure it's the same observer, because there's a lot of inter-observer variation. So if you're going to change the lab, if you're going to change the observer, that's where the challenge will arise. But if you're looking at tunnel and SCSA, then you've got to be more this thing with your protocol and the cutoffs, because they can be variable lab to lab dependent. So not so much observer dependent as it is protocol dependent, because then you're using flow cytometry, and there you've got to have more stringent cutoffs in terms of protocols and cutoffs. But otherwise, yes, they are less subjective if you're looking at something like SCSA, or you're looking at tunnel as using the method of
So, as
assessment.
you rightly mentioned, the which test is better, it has its own pros and cons. Sperm chromatin structure assay, halo test and tunnel, just now Amit sir has mentioned clearly, I don't want to go into this. But in your practice, when you are sending a patient for DFI testing, so what are all the precautions do you take? You send every patient to DFI, or already that indications I am not asking. How you send the sample? There is a practically how you send the sample for
This
DFI
is a
testing.
patient that has a good count, so we will get a DFI in him. The thing that you have to know is that if you have very low counts, it's going to be difficult to get unless you're in the UK and you're doing Comet for.
What is the threshold value where you cannot do SESA or SCD test?
So 1 million is said to be the cutoff, but I've usually seen very unreliable reports below 5 million. So that's my cutoff for the SCD.
Anything else, Dr. Parashuram? Because this is what we face as clinicians in our practice.
They should be able to see 200 sperms to be able to assess the SCD.
Yeah, I'm not the.
But, Dr. Mahmood.
We used to do it like up to 5 million. Below 5 million, we were not doing it before. But now we tried with the 2 million, 3 million, we are getting results. So we are lower the cutoff point. Now and to 1 million even, we are still getting results.
But the only challenge that we were discussing earlier is actually, is there a point in doing, because we just assume that they have high DNA fragmentation.
No, when we want to counsel your patients why there is a failure, you have to answer. The answer to that why there is a failure, that definitely it is a prognostication, it will be better. Maybe sometimes they may opt for donor also in some situations. Definitely we need to evaluate, just we not go with the assumptions, everything that will go. Anyway, this is carried away the same result.
I don't think we counsel any patient for donor sperm just because high DNA fragmentation. We don't counsel any patient.
No, just because you need to give options to your patients. There are patients, they have different thought processes also. But evaluation, it is an evolving process. Science is evolving now. There is no straightforward guidelines in this case. Whenever you are testing patient for sperm chromatin structure assay, the biggest lab, probably the highest number volume people, they accept if the count is more than 1 million, and if the volume of the semen is at least 0.5 million, 0.5 ml with 1 day abstinence. And you have to send in a separate cryo vials. Probably you should make sure that these are the practical things whenever you are sending these samples.
Actually,
and if the sample count is less than that, they will give report it is an insufficient thing. They cannot do that. If very few counts are there, maybe few sperms are there, if that is the case, you want to know DFI, where SCD test is also unreliable, where it, sir has mentioned clearly, there is a single cell gel electrophoresis, that is the test we need to do. But it is cumbersome. I don't think so it will happen in a clinical practice.
The point of that, the abstinence has to be short before you send it for a DFI is very important, because I think probably because that is a contributing factor to a DFI. If a patient is having a long abstinence, you send it for DFI, that might not be representative. So that information has to be very clearly understood.
So now what is your next step, Doctor? In this case, DFI is 45. So how will you proceed further?
Obviously, we'll take her for an IVF ICSI, and when I'm looking at an ICSI, probably I might think of using an additional sperm selection process. Now the options that are left to me is, now if I have an MC or a MAX system or a microfluidics, microfluid is actually very cheap, sir. It's around 4,000, 5,000 rupees. Actually cheaper than your DFI estimation, actually in India. So in our scenario probably, but then see, I think even when we are using these additional techniques, we should be very clear, like what sir was saying, we are only getting a cohort of sperm. See, if you're talking about MAX or if you're using microfluidics, we are getting a group of sperms, and hopefully that group of sperms probably have a lesser possibility of having DFI, or the number of sperms in them, the lesser number of sperms might be having high DFI. So you might be selecting. Even if you take single sperm selection techniques like a IMSI or a PIXI, where you're actually selecting one sperm, there also again the situation is, yes, see, none of these tests are directly looking at DNA fragmentation. IMSI, if you look at it, it's looking at the vacuolations. If vacuolations are present, this vacuolation is DNA fragmentation, nobody knows. It is only what we all understand is that the presence of vacuolation is probably, these group of patients who are having high vacuolations in the head are probably the sperms which are having higher DNA fragmentation, so we are removing it. But we still don't know if that vacuole is actually equivalent to DNA fragmentation. Second thing with PIXI, you are actually only looking at the affinity of that sperm to the hyaluronic binding site. So when you are actually doing PIXI and using that sperms, and when you are doing a DNA fragmentation level in those samples are lesser. So, but then still again, we are not directly correlating DNA fragmentation with the affinity of that sperm to attach onto that hyaluronic acid droplet. Similarly, with whether you took a look about max or microfluidics. See, microfluidics is what you basically, it's a channel. Say, for example, A to B. What sir was showing is a different microfluidic chip than what we use in India. Here we actually use a chip where you have A to B drop and there's a stream of fluid flowing. So if you have the sperms, which always will have a ability to to flow from one end to another end, if it is going against it. For example, the sperm is able to go away from the stream, or it has got the potential, so the more stronger the sperm to swim away from the stream of fluid is probably the group of sperms which are going to have a higher possibility of having less DNA fragmentation. And max is again about the apoptotic sperms, sperms with damage on top of it. So we are assuming the damage on top of it is probably the defect that damaged sperms can probably have higher DNA fragmentation. So we are removing all the damaged sperms and we are getting a group of sperms which are not having damage, which probably will have a lesser DNA fragmentation.
Guys, this is a masterclass. One second. Dr. Murray, I'll get you the chance. We just need to make sure the message is very clear, correct? So how many of you in this room think you will call your urologist or do a TISA for this patient? Show of hands. Very
Only
good.
one.
Okay, only one practitioner here. Excellent. Even though TISA was given as a recommendation and only one person is raising your hand, that is very good. The TISA used for high sperm DFI published by both Peter Schlegel and Sandro Esteves' group was for the first failed IVF cycle and for the second time. This patient has not even attempted an IVF cycle, correct? So to do a TISA on the first time except her, I'm happy that nobody else raised your hand. Ejaculated sperm is the best approach in this. Let's leave it at that, master. You know, this is not here to do controversy and to discuss research. You guys need to go home with very clear take-home messages. So high sperm DFI, first attempt at IVF cycle, attempt microfluidics like Dr. Shmuri mentioned, attempt short abstinence interval like Dr. Parasuram mentioned, and try to get the best ejaculated sperm quality as possible for the first cycle. Recurrent pregnancy loss, IVF with PGTA, I think is a very good idea to screen to make sure you decrease time to pregnancy. Second cycle, they come back, then attempting TISA sample, half the eggs with ejaculated sperm, half the eggs with testicular sperm, all of them are good. So I'm very happy that all of you are going to use ejaculated sperm for this patient.
Dr. Mahmood, any inputs? Because in the lab, what will you do? So Dr. Parashuram already has highlighted, probably we want your inputs. In this case scenario, what do you want? How do you proceed?
Well, actually, I was like comment on what Dr. Ranjit said. And if we have to, first time we have to use ejaculate sperm, and based on the history of that, if she didn't get pregnant or she got miscarriage, and we have to do TISA next time, so better to use like half, or at least, but at least to have history of ejaculated sperm with the IVF. And second, yes, of course, we have to use these technologies that are available for us in terms of selection of sperm that select sperm with low DNA fragmentation. I believe like all are good and they have lower, but still I prefer one on the other. And my preferred like technology is to use the microfluidics, which has like still you don't have to do a centrifugation step and will select sperm with low DNA fragmentation.
So you will go ahead with microfluidics followed by IVF or ICSI?
ICSI.
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 So now there is a recent trend in the embryology group. Now they are going back to IVF, where it is a more physiological selection. They are giving some chance when count is good. What do you think? It is a recent update from many embryologists now. They are thinking back again.
Technically, what happens in most of these scenarios is, see, obviously, the way to go forward is always do IVF as a scenario. But what happens in the current scenario, especially in Avenir syndrome, most of the people do end up doing ICSIs for all patients. So ICSI for all, even though not openly talked about, is what is happening in most of the centers. Now, scenarios like these where probably have higher number of oocytes. So probably these are the scenarios where we can actually split the eggs. Yes. And you do few ICSIs and few IVFs. And if you are getting good quality embryos in IVF and ICSI, obviously, your preferable transfer of embryos will be from your IVF cohort. But again, like I said, it's a more natural selection. So it's basically the oocyte is, see, whenever talking about sperm selection naturally, I feel it is correlating with your Swayamvara, where you have a oocyte and you have millions of sperms. The sperm selects that sperm And unfortunately, our sperm selection like shadi.com, where you actually select each criteria and then we select one sperm. Ultimately, that also might not end up giving us a pregnancy. But that's the kind of correlation that we need.
There is a one thing, probably split
Just before this, I just want to have a show of hands for how many centers still use IVF. Be a little listening about it as what percentage. So if I would say at least
Only
20% or 30% use IVF as a method, because most centers that I go to actually only use ICSI, like he's mentioned. So I would love to see that split of IVF and ICSI, but it's not happening. So, your patients, and there could be so many factors that could be affecting that. Patients looking at chemical pregnancies or whatever you have to show them, but I don't think, can we have that? Sorry. IVF, how many people? Oh, so there's still a lot of people that are still using IVF.
See, actually, technically, if you look at this patient, that patient's sperm's fertilization probability is already proven. She's made them pregnant even inside the pelvic cavity. So technically, generally in this particular patient would not have needed ICSI. But then when we actually doing it, we always end up splitting and doing. We don't do an exclusively IVF, but I don't know if anybody is doing exclusive IVF. You do an exclusive IVF? Yeah, please.
I'm here to question them. Antiphospholipid and recurrent pregnancy loss evaluation for female is normal.
A male infertility CMI. We have every female is normal.
It is a male fertility symposium.
Excuse me.
Yeah.
I just wanted to know, do you keep any cutoff for motility when you're using microfluidics?
See, microfluidics, I will get my out.
Any cutoff for progressive motility before you use, if, for example, if the motility progressive is 0%, total motility in the sample is just hardly 5 or 7%.
See, you want to answer
Yeah,
that?
of course. Yeah, of course.
So to extension, what are the limitations when you can't use microfluidics? Probably that will be better.
Of course, the microfluidic separation technique depends on the motility. You should have a motile sperm and that has forward progressive motility. If they are not in progressive motility, they will not reach to the other side of the slide, and you cannot use microfluidic in such cases.
So you go back to centrifugation then?
Yes, you have to do like a gradient.
See, I think what you should understand is that with microfluid technique, what we are doing, if you're talking about ICSI, we just need 1 or 2 sperms. So if at least 1 or 2 sperms are going to come and swim up to the other end, that is enough for us. Now, technically, most of your microfluid swim up process, most of the ones are talking of sperms that can be done when we do a ICSI. That is, we get only few sperms. But I think there are, I think the one that you are using, Zymot. Yeah, Zymot has got 2 options, wherein you actually have a cohort where you end up getting a little more number of sperms and you get less number of sperms. And the one in which you're getting a little more number of sperms, they even say that that kind of sperm processing technique is always also used for IUI. That is, you get that much enough sperms to do an IUI, but otherwise most of the sperm process, we end up getting enough sperms only for an IVF ICSI.
But you should have forward progression.
Obviously, you need to have forward progression.
Yeah. Without, will not collect sperm.
Any role of whole exome sequencing for the couple here?
That is one area where I mentioned, I was asking, these are the areas where unexplained infertility is there. If you want to evaluate further to detect for any asymptomatic infections or STIs or other thing, whole exome genome sequencing with next generation sequence. So even oxidative stress testing, which is not available, there is a MyAccess device with Cleveland Clinic, probably still it is not into the practice properly. Probably these are the areas we can explore, other than this routine DFI, whether to select directly going ahead with one of them, because we just heard the limitations of microfluidics also.
Why don't we take a break right now? There is an important announcement about checkout time from...
So we are running late. I think we'll stop the discussion right now and we carry on this discussion when we are going to break into small groups, and then we can carry on this discussion then. So we need to check out. Those who have not checked out, please check out in the next 15-20 minutes, and then we regroup again for the next session that we have, which starts at 12. With Farupin sir's talk. So we'll be starting. So those who have not checked out, please check out and come back. And then we start with the next session.
Thank you panelists. Just only one take home. You evaluate male properly, female properly before going to the IVF, ICSI, whatever. That is a take home message.